Yeah. I will not be talking much about investment, which my other colleagues have taken here. I will be covering from the changing trend from the manpower development and the medical education perspective. If you see, maybe even 50 years before, doctor was the key person. Whatever doctor used to say as far as the healthcare is concerned, that was the final say. But in the present scenario, perhaps it is the radiologist or the investigation, whatever they say, that is the final. So this trend, that is what I want to highlight, because what Dr. Nagar rightly pointed out, it is not the investment, it is the manpower requirement. Can we meet that challenge? And that is where we have to take care of the trend in the education pattern also. What I want to highlight here, presently you are giving artificial kidney, artificial heart, everything can be manufactured in the lab or by some engineers or by technology. So what the doctor's role comes, basically if we see maybe in another 2-3 decades, surgery will be done by robot, the organs can be artificially created. So what this doctor is going to do? What I tell my colleagues, for the future doctor is an engineer who can manage all these equipments, maybe who can manufacture the things, and keeping that in mind, if the healthcare going in that direction, then what should be our curriculum, what is our target group, and what will be the medical council role. From that perspective, I will put only 2-3 issues before you for as a thought. Maybe we do not know the answer. We tell, okay, medicine is both an art and science. So perhaps the human role comes as far as the medicine as an art is concerned. But in spite of all the technology, that art will remain, and that human touch, that the role of the doctor, and our training has to see from that angle. But when you call it as a science, here the role of technology is coming. And that technology, if you put into practice, with all these, if you see any hospital you go with the present instruments, and even in the ophthalmology, or any cardiology or neurosurgery, anywhere you go, it is the technology which you have even in the medical education itself. If I am not oriented towards making audio, video, 3D presentations, teleconference, then I am nowhere in the education also. Therefore, and presently if you see, in addition to the medical personnel, the core medical personnel, allied health personnel, another area person, the technical persons. Previously the technical persons were at a lower level, maybe OT technician, maybe they were trying to help in the medical laboratory technicians. But now the technicians are coming at a higher level, at an engineer level, the biotechnologists, maybe the biomedical engineers in the hospital, in the big hospital, now they are coming. And indeed from IGNU, we are recently developing a PG diploma in biomedical engineering. And our main target group is the engineers, the BTech people. And the curriculum that we are designing now, having a 20% weightage in the medical, 30% in management, and 50% in engineering. Perhaps this is the trend that is going for the future person who will be going to interfere in the healthcare. So keeping that in mind, can Medical Council of India regulate the curriculum? Because engineering curriculum is by AICTE. So what this product will be? Who will be controlling that? That is the area I am leaving for the debate. Another thing is residential training. If you see the Medical Council of India, the definition of student, a student has to be a full-time student. If he is doing anything part-time, it will be derecognized. He is not a student, so there is no question of recognizing his degree. But you see the present run of teaching learning. The technology can replace a teacher. If you make a good video, even there are already, I think the Hyderabad group and others are already, they have demonstrated that a part of the medical curriculum can be taught through audio, video, or through the softwares. Many things, they are there. But we have not accepted that as to replace part of our curriculum. So, should residential training be compulsory? That is another area. If we intervene there, then comes the role of IGNU, which is created for working students, for disadvantaged section. The thing is that a student can earn and learn. So when earning and learning goes together, that means he is a part-time student. So recognizing their degree as a valid degree at par with the conventional system, this is another challenge. So if we take care of this system of education, I think the issue that we are telling, that manpower training is a big issue, I don't think it is at all an issue. If we can utilize technology for training, like in IGNOU, we are having PG diploma in clinical cardiology. We are training 500 doctors after MBBS, 2 years residential training every year. That means if you can create 500 people trained in cardiology every year, we can solve the cardiology problem in under 5-10 years. But the issue is, are we going to recognize it and give them at par? So similarly, what I want to highlight here, technology has gone to certain extent. Any manpower requirement you put, it can be sorted out. The issue is to changing our mindset, making the regulations accordingly, and the acceptance by the larger society. I think I will stop here. There can be further cases.